Well, it was a long process. It took almost 2 years. It's a very stringent selection process. Just for your information, actually, very few centers in the country are doing this procedure right now. And because it is unlike a stent in the coronary artery, this is a very, very complex procedure, and it involves two cardiologists, 2 surgeons. So the FDA, Medicare wanted to be sure that this is done within safe limits, and therefore a lot of criteria had to be implemented to be selected. First and foremost, you had to have good results and experience with this procedure. We are the only hospital in Lexington with a Society of Thoracic Surgeons, which is the most credible thoracic surgery society with a 3-star rating. We have had extensive experience at valve surgery and have had very good results over the years. And last but not the least, we have the only dedicated valve center, which is a center dedicated only to valve disease treatment and management. And a lot of resources went into it, including building a hybrid operating room. And that's where we are. That's why we were selected.
Now, you mentioned valve surgery. There's traditional valve surgery. Do you think this new TAVR procedure is going to replace traditional valves? And tell us a little bit about heart valves, the types they are, and when you use certain kinds.
Well, aortic stenosis and aortic valve treatment is always a surgical management. And this TAVR procedure can be considered a variant of surgery. It is the most minimally invasive surgery that is available to treat aortic stenosis. When you have valve problems, especially aortic valve problems, I'm talking about specifically aortic valve problems, you treat them with valve replacement. And these valves can be bioprosthetic valves, which are either pig valve or beef valves, which are more commonly used because you don't need Coumadin. And the other kind of valve is a mechanical valve, which is a metal valve, which is being used less. And this TAVR is actually a bioprosthetic valve. Which is actually a pig valve that we use.
Now, you said Coumadin, that's a blood thinner. So if you have a pig valve, you don't need blood thinner. If you have a metal valve, you do?
That's correct, yes.
Does TAVR require blood thinner if it's in place?
No, it does not. We usually put patients on Plavix, which is not like Coumadin, so you don't have to have blood tested on a regular basis. But we do use it for about a month, yes, after the surgery.
But you operate on all valves of the heart.
Yes.
Is there a difference between replacing a mitral valve and an aortic valve, the different sides of the heart?
Yes, the aortic valve is in front of the heart, and mitral valves at the back of the heart, but they both constitute what is open heart surgery. We actually have to open the heart and replace the valves, as opposed to bypass surgery, where you actually do surgery on the surface of the heart.
Now, when you said bypass surgery, there are times when you do valve replacement and bypass surgery at the same time?
Yes, and that as patients are getting older, that is getting more and more common.
What's the difference between, or how do you know when you need bypass actually operating versus a stent? Is there a criteria for that?
Yes, I mean, this has been something which has been extensively studied, and the American College of Cardiology and Society of Thoracic Surgeons have actually implemented strict guidelines on which patients should get bypass surgery and which patients should get stents, yes.
And you do the actual opening of the surgery, but you also do a minimally invasive surgery.
Yes.
Tell me how that's different from regular.
Right. Well, minimally invasive valve surgery is, as I mentioned earlier, treatment of aortic stenosis is with surgery. You replace the valve. And there are different ways to do it. And traditionally, it was done through a breastbone, where you split the whole breastbone. And by and large, that still is the most common way to do it. But there are lesser invasive ways to do it, where we make a smaller incision. Instead of making an 8-inch incision, we just make a 3-inch incision and just split part of the bone and do it that way. And most aortic valve surgeries that we do at St. Baptist, which only, I'm talking about the aortic valves, are done that way. Now, the TAVR procedure really beats it all, where you don't need you don't stop the heart. It's done on a beating heart, and there's no incision in the chest. It's just done through a small incision in the groin, and patient goes home in 3 days. So it is revolutionary, the surgery.
Well, tell me again a little bit about the candidates for the surgery, because not everybody right now is a candidate for the TAVR. Most people will still get the actual open heart procedure? Absolutely.
The way it stands today, the gold standard is still traditional surgical aortic valve replacement. TAVR has been in Europe for about 10 years. There have been more than 60,000 of these procedures done around the world. But it's still in its infancy. It's going to take some time to get refined. I think maybe 5 years, maybe 10 years, but it's getting there. And there are complications with TAVR. So I think it is up to the surgeon. Actually, we at Baptist have a heart team. There are 2 cardiologists and 2 surgeons, which are four physicians make a decision whether patients should get traditional aortic valve surgery or get the TAVR procedure.
Do patients see when they get their valve fixed, do they see their symptoms improve?
Absolutely. I mean, you see a miraculous transformation of patients. I mean, patients couldn't breathe, and suddenly they have this breath of fresh air. They feel, I mean, I've had patients tell me, "Doctor, I feel alive again." I mean, it's truly a transformation that they really brag about all the time to me after surgery.
Now, we talked about valve replacement. Can you fix a valve instead of having to replace the whole thing? Is there such a thing as valve repair?
Valve repairs are traditionally done for mitral valve, which are leaky mitral valve, not for aortic valve repairs. They did try aortic valve repairs years ago, but it's not done for aortic stenosis. Mitral valve repair is classic in the classical sense is done for mitral valves.
Now, with the advent of statins, that's controlling your cholesterol, with exercise, with stents, are you seeing less heart surgery than you were 10 years ago?
Actually, there's a big paradigm shift. The center stage in the 90s and early 2000s was occupied by coronary artery disease, but coronary artery disease is now being displaced by valve disease, specifically aortic valve stenosis, because as patients are getting older, the baby boomers are coming of age, the valves stiffen, they harden, and you get aortic stenosis. So we are seeing an increase in the incidence of aortic stenosis and a decrease in the incidence of coronary artery disease, which is a good thing. I think doctors like yourself are taking good care of patients, watching the cholesterol, putting them on statins, and we don't see coronary artery disease as much. Yes.
Now, are there certain types of people who are at risk for valve disease? Is it genetics? Is it infection? Or just happens and we don't know why? It's
a process of aging. There are 2 kinds of aortic stenosis. One is, in one subset, it affects the younger age group. They're born with an abnormal valve called a bicuspid aortic valve. They usually get afflicted in the 50s and 60s. The other more common variant of aortic stenosis is in people in the 70s, 80s, and 90s, which is just a process of aging.
Percentage-wise, 5, 10, or a lot?
You know, after 80, I would say about 5 to 10% of the population has aortic stenosis of different grades, mild, moderate, and severe. And I would say less than 5% have severe, which is the dangerous kind, which is dangerous. Yeah.
And the symptoms you may get that would warn you need to see a doctor?
Chest pain, cardinal 3 symptoms: chest pain, shortness of breath, and just dizziness.
And if you see your doctor, now folks hopefully will know that they have an option other than replacement. They can get the TAVR also.
Absolutely. Absolutely. If I was a patient, I would want to go to a center which has both the options. I mean, you got to fit the surgery to the patient and not the patient to the surgery. So you have all the options. You know, the doctors can discuss it with you and give you the best option. So I think that's good we have it at Central Baptist.
Well, thanks for coming in. Tell us about this option. We'll be right back after this.
Thank you.